Good morning. This is Erin with the Department of Medicaid Services. It's not quite 11 o'clock and we're still clearing the waiting room, so we'll give it just a moment before we get started. Good morning. Evan, are you on? I currently have you and Susan logged in, and those are my only two TAC members. Would we like to wait just a moment? Oh,
Yeah.
somebody snuck in on me under a different name. Sorry about that. There's three of you.
Sorry, I'm here.
And
Morning,
Marlene is
setup.
joining us. Dr. Schuster does that to me on the behavioral health tax. She always logs in under a different name, and it's like trying to guess if she's on.
Yeah, I'm on a borrowed computer. My last one died, and we're getting all new ones, so I'm just using one of the old ones until then.
Well, I currently show 4 out of the 5 of you logged in. Did you want to wait a moment longer, or did you want to go ahead and get started?
I think we can go ahead and get started. Hey, we just might log in here in a little while. Well, happy hot day to everybody. Hope you have a cool place to attend this meeting from. We'll get started with the introductions. I'm Aylin Purden with Hazelwood Home Health.
Susan Stewart, Appalachian Regional Healthcare.
Janet Marlene Reynolds, LHC Group.
Is that everybody? Okay. And next is approval of the minutes. We have a motion for the April 29th, 2025 meeting.
I'll make a motion. Susan Stewart.
Second, Marlene Reynolds.
All in favor? Aye.
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 Okay, is it just me? Evan, are you muted? I can't hear you. Everybody else hear Evan?
I can't either. I thought I'd missed his introduction.
No, we can't hear him.
He must be having to log back in. Okay. So I believe I heard him mouth I, so, or I saw him mouth I. So I think that is approved.
How's that? Can you hear me?
Back.
Still very low, Evan.
Is this better?
A little bit.
Okay. I'll try to speak up.
There you go. Now I heard you.
Right.
All right. We're at old business. You want to do it, Evan, or?
Sure. Yeah, let's dive in. First thing is supplies limits. So I know we were waiting on some feedback from DMS on that, I believe. So Aaron, I don't know if anybody is here to speak to that from DMS.
We actually have Jeremy Armstrong is going to be joining us today as well to cover the MCO side of that. He is going to jump on as soon as he's out of another meeting, but I did see Carmen come on camera, so I will turn it over to her.
Yes, and I think Jeremy will probably be able to speak better to that, but this is just something that we're looking into. Um, and unfortunately, I don't have a great response for it right now, other than we're doing research.
Okay.
Yeah.
Is there?
And Evan, I know some of the emails that I've gotten in the last couple of days were from you. So, with regard to those, you know, the codes that are kicking back out and the ones that won't go through, and there seems to be a discrepancy with the revenue codes and that sort of thing. We're working on it, sir.
Okay. Yeah, if there's anything we can help with, and I mean, really, like, this one's a bit frustrating for us because it's years in the making.
I saw that on the strings, so absolutely understood.
Okay, so please do let us know how we can help. You know, really, we're just trying to hit that target because you know, these things reject and we play a guessing game with the MCOs, and you know, it just seems like a big waste of everybody's time. So, you know, we definitely want to see some progress if it's at all possible.
Yes, sir. Absolutely.
Thank you very
Thank
much.
you. Sure.
And Evan, just for the rest of the TAC, do you mind to give them just a quick rundown of the emails that Carmen mentioned and the
Yeah, and
codes?
so I don't have the codes offhand, but the nature of the specific issue is, you know, that we're trying to bill for supplies, and the one example we go back to is the 4x4s. I don't remember the specific code for that, but basically there's X number of 4x4s. Those that's just a like gauze bandage, right? Susan is how you would describe it. Um, and there are X number of those in a box, and the plans have a specific number that can be billed, and anything above that will reject. But based on the number that's in the box, you know, so the agency's bill, let's say there's 5 in a box. The agencies figure out they're going to need, you know, 10 of those for whatever the time period is. So they bill for those 10, you know, at 50 items, and the magic number for the MCOs is 49 are approved. And so then they try to bill for 50 and it gets rejected. And then they play a guessing game because then they're like, well, we need 50, but only 49 can be approved. How do we cover this, you know, given that the supplies need is X amount? And so we've gotten into a dialogue about, you know, some discussion about that number being proprietary, which we understand. You know, we don't want to play games in terms of getting extra supplies, but that's not what we're after here. You know, we're trying to appropriately supply the patient and not get a rejection for, you know, what really in our minds, you know, I get it. There's a formulary, there's a bit of math to it on the MCO side, but you know, for us, that's just an arbitrary number that gets picked that, you know, is then rejected, and then we've got to go back and resubmit the claim and then deal with, you know, the difference between whatever gets approved and whatever was actually needed for the patient. So it turns into a whole bunch of administrative time that, you know, really could be resolved by just transparency with, you know, here's what you can bill, you know, for in terms of the number of supplies. So
Well,
Susan, it looks like you have something to add.
I do, and it's not, they don't pay for the 49. They deny the whole claim. And so you don't, even if 50 is excessive, you don't get paid for the 49. It's just the whole line is denied. And the other part of that is there was discussion about whether it was proprietary or not, but we stand on the ground that proprietary thing is not related to home health, it's related to DME, correct, Evan?
Yeah, so we did some research, talked to our national folks. They've never seen CMS put, you know, I forget the title of, you know, the CMS grants when they allow those things to remain confidential, but the home health element of this has never been given that designation by CMS. So these ought to be, as far as, you know, best of our knowledge, all of these ought to be able to be published so we can understand what those limits are and not have to deal with the, you know, the back and forth on getting the denial.
And every CMO, every MCO's threshold is different. So one might be 49, one might be 42, one might be 30. So it's just arbitrary.
So good morning.
Okay.
Sorry, this is Jeremy Armstrong DeRossett with the Department for Medicaid Services. For my role, and just wanted to step in here and ask for potentially, has any examples been shared with the department as far as this limit that's being described here at the MCO level?
For 3 years.
Okay, so examples have been shared.
Yep.
Would some of the members be willing to share those examples with me directly so that way I can research into this issue? So again, with my role in the state in this department, I provide oversight to these MCO contracts. And some of what I am hearing does fall along with some of the utilization management rules that we do afford MCO partners when it comes to creating or utilizing that criteria met. So either interqual or the MCG guidelines should be utilized in some of these descriptive areas that I'm hearing. We also have a process here within my team. So I have the contract monitoring branch that provides that additional support and oversight to these MCO partners' policies and criteria that they do have in place. So I'm also going to share in the chat my direct contact information, also a MCO dispute form, which is the provider's opportunity and way of getting engagement with the department directly from the oversight of a contract to research into these types of issues that's being described. I would like my team and myself to further look into this supply limits and the home health aid utilization and some of the issues of denying claims that you're experiencing with WellCare. And this team will be able to provide that support and oversight from the MCO level, not only engaging with the providers directly, but more so engaging directly with those MCOs to ensure that there is an alignment to what is state required and federally required.
Awesome. Yeah, if you can throw your email down in the chat, I'll shoot you an email right away and we'll get started on having some dialogue on that.
All right, sounds
Thank
great.
you. And Jeremy, this is Carmen with LTSS. I just forwarded you two chains that I was working on,
Perfect.
and where I had gotten to on them. So if you want to take a look at those and try to pick them up, in addition to what Evan might send you. Thank you so
Absolutely.
much.
Yeah,
Very much
thank you.
appreciated.
No problem.
And I just wanted to add that by the MCO not giving us this proprietary magic number, it puts us at a hardship that say that 45 is the magic number and we think the patient needs 60, or the patient thinks they need 60. We can't tell them, okay, your insurance will pay for 45. So you will either need to go buy these or you will need to buy them from us. So, I mean, it just puts us at a disadvantage. So what happens is we just give them out for free.
To answer the question in the chat, it's various HCPCS codes.
Okay, so there's not one particular code that's like standing out more than others.
No, it's multiple.
Okay.
And Evan and
yeah.
Stuart, I have shared everything with Jeremy's group as well over the past few years since I've been involved trying to work on this as well. So he does have some backdated information, email chains and so forth.
Okay.
Awesome.
And Jeremy, if you need any for Humana, you have my contact. I have no problem researching examples and trying to figure out what's going on. I don't recall, at least for Humana, I don't recall having proprietary logic for for units tied to this? I know most of the time they're tied to MUEs that CMS has published, but yeah, I'd be interested in just doing some additional research.
Okay, thank you, Mr. Ellis.
That's what I was referring to earlier. You know, we asked our national folks about the MUE for, you know, home health specific elements, and they've told us they've never been made aware of CMS designating the home health side of this under the MUE category. So, you know, the DME side, you know, maybe a different conversation. Maybe that's where we're losing things in translation, but, you know, at least the home health side. I mean, and to Anlin's point and Susan's point, you know, if we're billing for 4x4s and the patient needs 50 of them, like we should be able to get those 50 to the patient without, you know, 6 to 9 claims and 7 resubmissions. I mean, that's what we're trying to avoid here. So hopefully we can make some progress on that. All right, do we want to go to home health aid utilization?
Jeremy,
So I know
this
that.
is Justin Derringer, can you include me on the supply issue?
Absolutely.
Thank you.
All right. Do we want to jump to the home health aid utilization? I know there was some conversation, I think, with UHC in particular. They were going to do some investigating internally. You know, our big concern here is just the dramatic cliff that we've seen in terms of the drop off in utilization over the last 18 to 20 years. So didn't know if DMS has anything further on that. I know I think United was looking into it internally, but you know, wanted to just get that conversation, keep that conversation going.
Hey, it's Suzanne from United. We were looking into this, and I apologize. I don't have an update today, but I can bring it back to next time if that's all right.
Okay, sure. I mean, what can we do to help in the meantime, Suzanne?
I don't have an answer. Just,
Please let us know. Again,
yes.
this is a top priority for us. I mean, it's again, would think it aligns with the state as well as the MCOs too. You know, these are the least costly folks to send out into the community, and we're not utilizing them. So, you know, something we're trying to prioritize.
Yeah. A couple of things that I have done, just so you know, internally, like reaching out to other markets to see what their utilization looks like, what kinds of, what, you know, again, what they're used for, get an idea of other markets so that we have some comparison, and then just looking into some of our data. Now, you know, we're the newest MCO in the group. We've been in operation about 4.5 years. And so our data only goes back so far, right? But we can at least look around and kind of get a better view from more of a national landscape. We're in many markets for Medicaid. And so I think that would at least give us a, you know, kind of a better view of what it looks like as a whole, and then help to kind of have that conversation. So if you'll, I need just a little bit more time to gather some more information, and then we can come back next time. Is that all right?
Sounds good. We'll hold you to it if that's okay.
Definitely. Thank you.
All right. You're welcome. Any other discussion on the home health aid utilization piece?
I have a question from, I guess, for the department. You know, what is their response to knowing that there's been a complete erosion of the home health aid utilization? Did you hear me, Evan?
I heard you. Yeah.
Okay, just checking.
Yeah, Aaron, I don't know if the DMS, anybody from DMS, I mean, we would hope this would be a priority for you all as well, just to understand, more on a macro level within the HCBS, group, and industry, and, the approach from the cabinet and DMS. We think all this aligns with the goals collectively. So, that's something we would hope is a priority for DMS as well.
I will put that on my take back email.
Well, I was just wondering, since somebody mentioned this MCO dispute form, which I'm not familiar with, is that something that we can fill out when an MCO has denied an aid that we believe under traditional Medicaid would have been covered for
So
the
yeah,
policy?
yeah. So this is Jeremy Armstrong again with the department, and again, the MCO dispute form is that ability for the provider to directly engage with the department to review an issue, whether it's resulting from a claim experience, a credentialing issue, a contracting issue. But the department will always emphasize the importance of following through your MCO's appeal process internally to dispute those claim experience that you are having. So again, the MCO dispute form is something that providers can utilize to bring an attention to the department for something that can be researched into. But I don't want that to be construed or not allow a provider the appeal level rights, because those are all very timely. Because if you come to the department to request research and review of an action or a claim experience, our research and review may fall supportive of that MCO partner, but then that decision could be beyond that timely process to request an appeal for that claim. So again, it's not the emphasis from the department to not utilize that dispute form to bring an issue to the department's attention, but understanding that there are appeal level rights that you should be following within your MCO's agreed upon negotiated contract that you have with that plan.
So the problem with that is it's on authorization. So somebody has surgery, they come home, they need an aide to help them bathe for a few weeks until they get better. Well, the MCO denies it. Even if you appeal it, that's going to take another week or two. Well, they don't need you by the time you either get approved or denied. I mean, we've had the experience of we've appealed it, they approved it, then we call the patient and they're like, well, we're better now.
Oh, okay. Any opportunity, has any action been taken as far as requesting any peer-to-peer from that decision of a denial from the prior auth? Maybe an engagement directly with a peer-to-peer may result in a different manner?
I'd have to ask authorization.
Okay. Again, though, the department is here to support the provider networks, and we will be happy to research into anything specific that the providers are having an issue or concern with within that MCO plan. Just understand again, when it is claim involved, the appeal level rights is important for that process and experience, but also that MCO dispute form could be used for any type of research that you would wish for the department to look into further.
Thank you.
Yeah, there is also in that MCO dispute form, once you open it up and kind of review, that one pager kind of details a little bit about that experience of expectation when it comes to appeal level rights, making sure that providers are following that opportunity to appeal that decision or appeal that denial. And what that appeal level does afford is that MCO partner to identify an issue within their system, identify an issue within a policy per se, but also allow that MCO the opportunity to rectify and resolve an issue with those providers directly.
Thank you.
Yeah, no problem.
At one point, wasn't there a a plan for Medicaid to reach out to the providers to do a questionnaire for the MCOs on how satisfied we were with them related to the services that we deal with them on?
Yes, the department did complete a provider survey that wasn't just specific to providers. We also sent a survey out to our association members. I believe that some associations received it, providers received it, some members also received it. And so we are currently reviewing the responses to those surveys. And it did not appear that we had a huge volume of responses from providers. Now, a lot of what we did see is what we typically experience and hear from the vocalization with prior authorization denials, claim denials, policies. Those are similar type of experiences that we heard in those surveys, just readily looking through those. We did just recently this week review those responses. So there was a survey that the department did send out.
Okay.
Was that specific to any particular area such as home health, or was it very broad and generalized?
It was very broad and generalized. So it was questions specific to just kind of an experience from a provider standpoint, also an experience from the member standpoint as well.
Thank you.
Yeah.
Evan, this is Carmen. Could we go back to the home health aid utilization?
Sure.
Could you give me some background on that or clarify that concern? Is that just, is that home health aid utilization by through an MCO or through fee for service, or is it just a concern that that particular position is underutilized, or?
Yeah, so and I can pull up the information here in a second, but I think combined, so when you looked at fee for service and managed care, we went from somewhere around 106,000 visits in about 2006 to I think it's under 6,000 in I want to say 2023 or 2024 was the latest data we saw. And that's just an incredible decrease of, services being delivered by home health aides. And it has risen to the level that a lot of folks just can't even really employ an aide because they don't have anywhere to send them. If they're not getting authorizations to provide that service by the plans or by fee for service, they just have an aide that's sitting around and they can't, send them out to work with a patient. And again, it seems a little odd just from a workforce standpoint because, they're important pieces, home health aides are important pieces of the home health landscape generally, but also, tend to be the more economic means of delivering care and operate, I think most importantly as an opportunity for agencies to have more touch points with patients so that they can avoid hospitalizations. You don't want to necessarily send a nurse out for everything. You want to be able to send out an aide that can touch base with that individual and sometimes just check in on them, see how they're doing, and interact and to make sure that their condition isn't deteriorating, for any of the reasons that, they haven't been eating well or just, haven't been following their treatment regimen or whatever the case might be. So I don't know if Anlin, Susan, or, Marlene, you want to add anything to that?
I'm sorry. And I still only caught half of everything you said, but did you say the numbers of like how much it's decreased?
Yep.
Okay. Yeah.
Hey,
Carmen.
Evan. Oh, sorry.
No, go ahead.
Evan, did we have an idea of what was like, and I apologize if you said I may have missed it, what was driving the drop? Was there a understanding, generally speaking, what might be driving? Because
Prior authorization.
Yeah,
prior authorization requirements. Okay.
yeah, it's just the agency submit for the service and it gets denied. That's my understanding. That's, and again, anecdotal, but we're just not seeing approvals for aid services.
And over time, it's just a service that we've had to drop because, like Evan said, you can't employ someone and them not be productive. And there's not, 100,000 visits to 6,000, 6,008 visits would be 2/8 for the entire state, 3 at the most. So, you know, it's impossible to provide coverage.
Okay,
Uh-oh.
that's
Okay.
really helpful. Thank you all.
Yeah, it's similar to prior, Jerry Armstrong, but as well, I'm tied to claims, but again, I'm more than willing to look at examples and see if there's something. This is freaking man, if there's something we can do differently on our side.
I don't know that there's any kind of review that can be done right now, because I would say most of us aren't requesting it anymore because we can't sustain the workforce. It's more along the lines of what are we going to do to address the fact that what happened in the industry has led us to this, and how do we get it back?
Okay.
Carmen, I bumped that data to the top of your email.
I feel
Thank
like
you, Erin. Thank you, Erin. Appreciate it.
what we see is the MCOs, traditional Medicaid went on any willing family member that is able to help them. And there's just quite often a son or a grandson that doesn't want to baby's mother, and I don't half blame him. And under traditional Medicare, or Medicaid, sorry, that would be okay. But with the MCOs, it looks like if there is a family member listed in there that lives with them, it's just they won't approve it.
So just to clarify, so really then so is that very prescriptive to who's rendering it is when you're seeing these issues versus just generally the PA being an issue? In other words, if it's really tied to family members, then you're seeing a high denial versus non-family members?
I feel like if there's anywhere listed on there that they have somebody in the home living with them, a child, a grandchild, niece, nephew, if there's somebody in there, then it's denied.
Okay.
And usually the denials say they have family. Sometimes it's even if they don't live with them. You know, if the nurse has put in her assessment that, you know, there's a daughter that, you know, checks in on them and does the grocery shopping, and they'll just say that there's family that should be providing that for them.
You know, and in the home health, the word willing and able, just because they're there doesn't mean they're willing and able. And they can assess if, you know, if there's a change in a skin condition, family members can assess that to get an RN out there.
Anything else for the home health utilization discussion? All right, we'll jump down to the WellCare claims issue with the W520 HIPS codes. Amlin, I think that was you, right?
Yeah, I mean, I'm having that issue, and I'd heard from another agency they're having it. Figure is Stewart on.
Hey guys, this is Aaron Allen. No, Stewart is not on with us today. I don't think he'll be joining us anymore. But unfortunately, this is still an ongoing issue that our leadership is working on. It's as a high priority, but that's the only update that I have on it as of right now.
Okay, I guess I'll be seeing you in a little while. You're gonna pick up some paperwork on it.
You sure will. I'm actually en route. I'm sitting at McDonald's at the moment, but I will be there soon.
I'll see you shortly. Thank you, Aaron.
You're welcome.
All right, so more to come on that issue, sounds like.
Yes.
And then jumping down to new business, I think our only other topic was there another claims issue that we had sent over to DMS there, Amlin, just at the tail end? We had two separate ones, I think.
Yeah, and you sent them to DMS. So I don't know. I didn't have them to discuss. The one was the code that's denying the A6199. I don't remember what it was. We had it on last month. Yeah, the
I'll
A6199.
double check it. I think we sent it over late, so I'm not sure Aaron's had a chance to.
I have bumped it up to where it needs to go, so it probably needs just a little bit of time for some research and
Okay, that A6199, Aaron.
And the
yeah,
other
I
one,
think I currently have 3 emails out for you guys with
Okay,
some different
yeah.
things.
Then there's another one just with 2 claims that Anlin had passed along. So we'll
yeah, I think that those are just kind of a one strange thing. It's probably a system hang up or something. So hopefully once they research it, they can figure that one out.
Okay, we'll jump down to general discussion. Any updates from the MCOs?
I guess Humana will go first since I've talked so much already. Nothing that stood out for us. We're pleasantly surprised on the EVV process. It still seems to be going pretty smoothly. The only hiccups we've ever seen is where there might be a delta between the time frame where home health might use their specific clearing EVV vendor versus getting into the state's EVV vendor. But it's been few and far between where we saw those types of claim issues. And we've already talked about the other one, so I'd be interested in the examples for the units that we talked about. And then I've already forwarded a question over about the prior auth items if Humana has something similar in terms of the home health aides. Thanks.
All right.
This is Suzanne. Hi from United. I don't have an update on anything going on with the EVV process. I haven't heard any, let me say it differently. I haven't heard anything and I'm going to take no news as good news. So it sounds to me like things are going well. And then as I spoke earlier, doing the deep dive on the home health aid issue, looking at that a little bit more globally. And then, shoot, I had one more thing and it just left my brain, but if I think of it, I'll come back to it.
Thanks, Suzanne. So we've had Humana and WellCare, Humana and UHC, anything from WellCare?
Hi, yes, this is Aubrey Harmon with WellCare. No additional updates, trends, or issues today.
You?
Hi, this is Crystal with Aetna Better Health. I don't think that we have anything to bring forward, no new trends or any denials, prior auth, anything that stands out as being significant. I do think that the EVV process is going well. I think we've had a couple of provider questions, not really system issues, just questions in general. But other than that, I think everything looks good.
All right. Are we, I think we're down to Passport.
Hi, this is Teresa. Teresa Slattery from Utilization Review. Can you hear me okay?
Yes.
I don't see other representatives from Passport Molina on here. If they are, please feel free to speak up. But from the utilization review perspective, we don't have any other issues or problems to report. And the last time that I checked with our project managers, the EVV process was working as intended.
I'm Donna Moore. I'm with Passport by Molina. I'm the provider relations representative for Region 6 and 7. And I don't have any updates. Haven't heard anything. Looks like everything's going well. Thank you.
Thank you.
Thank you, Donna.
You're welcome.
All right. I think that's everybody, right? So we'll go down to any updates from DMS and or Commissioner Lee.
Commissioner Lee is currently out of the country on vacation, finally. Woman never takes a break. But I will turn it over to the rest of DMS staff, but I did want to let you know the commissioner is not going to be with us today.
Thanks, Aaron.
This is Jeremy with DMS. I don't have any updates to provide.
This is Carmen. I don't have anything either, but we will be working on the items that came up today. So thank you all for sharing and clarifying.
All right, any others? Okay, thank you all.
All right.
I don't think we have any recommendations for today just yet, but we might have some after our conversations on the supplies limits and other topics. So that just leaves us with MAC meeting representation, which Susan will be our representative there, and then next meeting date.
Which I did not update, so I apologize. It's August 12th.
That's it.
And just a friendly reminder, Susan, I know you're always on the MAC, but the MAC for July has been canceled. Once we get the new schedule, the dates we have currently on the calendar, I'm going to say are probably 99% likely going to change based off federal rule with the back meetings. So as soon as I have that information, I will get that out to all the MAC members and the TACs and everyone. So I've just been friendly reminder that there won't be a July meeting.
Thank you. I realized that, and so thank you for the reminder.
I have to keep reminding myself. I started trying to prep stuff for it the other day and it's remember that it wasn't there.
All right, anything else from the group?
On our next TAC, we probably really need to go back to EDV. My denials have just exploded, and it is, you contact their app, they tell you to contact the insurance, contact the insurance, they say to contact their app. I've got so many emails to all the MCOs and to their app, and there was a lady with DMS that we were sending some to, and I've sent them there, and I still sit here banging my head against the desk.
And Lynn, this is Laura Presley with DMS. If I'm gonna put my email in the chat, if you don't mind to send me your EVV denials,
Okay.
I'll take a look at those and look at this for you.
I mean, I even had a new one today that they brought in, and I hate when they have Humana Medicare and Humana Medicaid because we're billing Humana Medicare, but they denied all of it for not having EDD. And I'm just like, oh, okay, here we go. Not that Medicaid can fix that one. We just have to call Humana Medicare and get it fixed, but
Humana Medicare is denying your home health for missing EVV?
Yep. And it's usually the other way around. It's usually when we bill Humana Medicaid, they deny it, saying we should have billed Humana Medicare, even though it's not Medicare covered. It's just always, I think it's a system thing that the system doesn't really realize when you send it in if it's a Medicare or a Medicaid claim. So it's just a work to get it reprocessed.
That'd be another one I'd be interested. There is a way to get that to our system so it never hits our Medicare side. There is a way to submit it to always go straight to Medicaid.
Cool. I'll send you an email.
Yep.
See if you can teach me that trick. I haven't learned it yet.
It's not a problem. It's not a trick, but that's no problem.
Thank you.
Yeah.
And thank you, Laura. I will send those EBV examples to you. That's all I had.
Okay, anything else from the group? Oh, hear nothing, we'll take a motion to adjourn then.
I'll make that motion.
I'll second.
All those in favor?
Aye.
We
Thank you,
are-
everyone.
Thanks, everybody.
Thank
Everybody
you.
have a great day.
You.
Take care.